Hi students, this is Dr. Penrod again, and I am going to be going over alterations in immunity. Hypersensitivity reactions, autoimmunity, lupus, and AIDS. Okay, we're going to go ahead and get started here. So the first topic that we're going to talk about is hypersensitivity reactions. And we touched on that a little bit in the previous PowerPoint. A hypersensitivity reaction or allergic response is when we have increased or excessive response in the presence of an antigen to which the patient's been exposed. So, some people who have allergies, the degree of reaction can be just uncomfortable, such as myself with seasonal allergies, allergies to the environment, and it can progress all the way to life-threatening types of reactions. There are 4 different types of hypersensitivity reactions, and we're going to look at each of those in the next few PowerPoints. So the first one is type 1 rapid hypersensitivity. This is also called atopic allergies. It's the most common type of hypersensitivity. It's when the IgE responds to an antigen and releases histamine and basophils and eosinophils in response to that antigen. So some examples of type 1 hypersensitivity is when a patient has allergic asthma, hay fever, they have allergic rhinitis, they have allergies to latex, bee stings, peanuts, iodine. Some people have hypersensitivity reactions to shellfish and certain drugs. So I can use myself as an example. I'm allergic to penicillin, and that was discovered when I was a baby. So if I'm given penicillin, then my body produces this rapid hypersensitivity reaction where I have a histamine release of basophils and eosinophils. I become, I can start swelling, I can start having severe shortness of breath. Anaphylaxis is when a person has an allergy to the extent that it closes off the person's airway and they can't breathe in response to that reaction. So type 1 hypersensitivity reactions could either be inhaled, such as like pollens, spores, animal dander, house dust, grass, ragweed, those kind of things. They could be ingested, like some people have food allergies. Well, I use the example of myself with penicillin. Some people have reactions to food additives, like they don't do well with MSG in food or different additives that they have to watch out for. Actually, I remember working with a child who had an allergy to the red food dye that they put in different drinks like Kool-Aid and Hi-C drinks. This red additive would actually cause her to have a rapid hypersensitivity reaction. And then, of course, injected things like bee venom. Some people are allergic to bee stings, injectable drugs, different biological substances that are injected in the body. And then through contact. So for some people, even touching the food or touching something in the environment that has an allergen can cause the person to have this rapid hypersensitivity reaction. Angioedema is a term for when the patient has a severe type 1 reaction. It involves the vessels, the skin, the mucous membranes, the subcutaneous tissue, and it's just an exaggerated form of the hypersensitivity reaction. It's when IgE is released, causing inflammation. The patient with angioedema has swelling of the lips, the face, the tongue, the larynx, the neck. It can happen to exposure to any ingested drug or chemical, and it can be caused by ACE inhibitors. So a person who starts out on an ACE inhibitor, we need to monitor them for angioedema. And here's a picture of a person with angioedema. Angioedema, all that swelling from those different areas from the previous slide, can cause a patient to go into anaphylaxis. So, I'm crossing over into med-surg a little bit. Someone who goes into anaphylaxis, just listen to what they're saying, because you may not see the angioedema right away. It may be they may state an uneasiness, apprehension, weakness, maybe a feeling of impending doom. They might talk about their skin itching. They may have some pruritus and urticaria. You may also see the erythema, the redness. You may see the angioedema of the eyes, the lips, and the tongue. And this is a picture of a patient with angioedema. You can tell her upper airway is swollen in this picture. So other symptoms of anaphylaxis is I have listed on this slide: congestion, rhinorrhea, dyspnea or shortness of breath, wheezing, crackles. It's all when that airway has been compromised. We have inflammation of the airway that's preventing air from moving in and out. So you'll either hear wheezing, crackles. You may hear decreased breath sounds, and as the airway starts closing off, you'll start hearing stridor and the patient being hoarse. And then the patient will have laryngeal edema, suffocation, lower airway obstruction, and hypoxemia, which means a decrease in O2 levels in the bloodstream. Patient will become hypotensive. You'll notice a rapid, weak, irregular pulse. The patient may actually, because of the hypotension and the decreased breath sounds, the patient will start feeling faint and diaphoretic, and in extreme cases, changes in level of consciousness. So dysrhythmias, shock, cardiac arrest, those kind of things. Type 1 allergic rhinosinusitis is when we have a reaction to airborne allergens. It's a type of type 1. It's just an example of a type 1 hypersensitivity reaction, where we have the allergic rhinosinusitis, where we have this reaction to airborne allergens, molds, dust, animal dander. For some people it's seasonal. For others, they have allergic rhinosinusitis all the time. It can be inherited. You may have a family member who has an allergy. It could be that, like I use the example of myself having an allergy to penicillin. Well, then my daughter, because there's a family history of allergies, she may develop allergies, but she may not develop the same allergy that I do. So hers might not be penicillin. Hers might be, pollens, animal dander, or a different medication, But what happens is the allergen binds to IgE, which causes that release of histamine. And when histamine is released, it causes leaking of the capillaries. It's the nose and the eyes start making mucus, itchy eyes, redness in 10 minutes. It triggers white blood cells to the area that triggers the inflammation that we talked about earlier. And so, this is, I could have taken this slide out, but this is what we do. We draw labs and we observe our patient who's having these problems. And, if they have an increase in white blood cell count and an increase in neutrophils, the patient has an infection of some sort. So, these reactions don't necessarily mean the patient has an infection. But if you see a rise in the white blood cell count and a rise in the neutrophil count, then you might predict your patient has an infection. Okay, type 2 cytotoxic reactions are when antibodies are formed to attack self cells with foreign proteins on them. So this type of reaction, some different examples of these would be people who have a reaction to a blood transfusion. There's different anemias that occur that are this type of hypersensitivity reaction, where it's a cytotoxic reaction. Or patients who have hemolytic anemia that's been induced by some drug. Okay, type 3 immune complex reactions. This is when we have an excessive amount of antigens that cause these immune complexes to form in the blood. So this is why I mentioned that these are rather large complexes. So when this happens and they're released into the bloodstream, they actually can lodge in small blood vessels. So, and when they lodge in these small blood vessels, they cause an occlusion. So that's what an immune complex reaction is. So usual sites of occlusion of these large molecules could be the kidneys, the skin, the joints, and small blood vessels throughout the body. When we talk about acute and chronic renal failure, we'll revisit this again. But this is one of the causes for a patient who goes into acute renal failure. And then chronic renal failure is that these large molecules get lodged in the kidneys themselves. So type 3 immune complex reactions, like I said, these complexes they're deposited. They trigger inflammation to that area, not just occlusion of the area, but they also trigger inflammation around that area where they're lodged, and they cause tissue and vessel damage. So different disorders such as rheumatoid arthritis and systemic lupus and serum sickness are examples of disorders in which this immune complex reaction takes place. And we'll talk about these in a little more depth later. And the last type of hypersensitivity reaction we have is type 4. And this is when the T lymphocytes have a delayed reaction to the antigen. And instead of it happening within a few hours, this delayed reaction could occur hours to days post-exposure. So that's why it's important for us to monitor our patients who have this history, especially if they're exposed to something new that they have, like a new medication they've never taken before, because they could have a delayed hypersensitivity reaction where they have edema, they have, the area becomes indurated, ischemia, tissue damage to that site. So some examples of a delayed hypersensitivity reaction would be what our reaction is to the PPD skin test. So we do the first test, and then we wait 3 days, and then we look at that test to see if there's a delayed hypersensitivity to that antigen that's been injected in our arms. So other examples could be contact dermatitis, poison ivy, and I have to be honest, this has happened to me before, where it's really odd because I will go out and work in the yard. I love to garden, and my arms will start itching instantly. So after I'm done working, I'll go take a shower. But it's really been interesting. Like in 2 days, I start itching again, and that I believe I have this delayed hypersensitivity reaction to poison ivy, because I take care of the exposure immediately afterward, but then a couple of days later I start breaking out into a rash. So insect stings can trigger this, and tissue transplant rejection, and a lung disorder called sarcoidosis, where it's when an antigen has been exposed inside the lung, and it causes this delayed hypersensitivity reaction that causes the patient to develop sarcoidosis. All right, so we've talked about all these different hypersensitivity reactions. And the one in particular, let me go back a little bit. The type 3, now we're going to talk about autoimmune diseases. So those are types of type 3 immune complex reactions. So autoimmunity, patients who have autoimmune diseases is when the immune system cells, they don't tolerate self cells and they react to them. So there's some kind of problem with the patient's ability or the person's ability to recognize self from non-self. So when this happens, when the immune system of people who have disorders such as rheumatoid arthritis and systemic lupus, or SLE, when they have these disorders, their immune system just does not tolerate their own cells. So their antibody and their cell-mediated immunity is directed at the self cells, and they develop autoantibodies to cells within themselves. So patients who have autoimmune disease, it can be directed at specific tissue, the hypersensitivity response, and the autoimmunity, or it could involve multiple organs. So autoimmune disorders, there are so many, and they, like this last statement says, it can be targeted to a specific area, or patients who have autoimmune diseases, it can actually be a multi-organ type situation where the body, where the person develops these autoantibodies that end up attacking the patient's own cells in multiple organs. So one in particular we're going to talk about is lupus erythematosus, systemic lupus erythematosus, or SLE. So this disorder I actually have personal experience with. My mother had lupus for so long, I mean, as long as I can possibly remember. And, she did very well with this diagnosis over time. She ended up, she passed away from lupus shortly before I took this position at SIU. So she passed on in June of 2020 from the complications of lupus. Lupus is a chronic, progressive, inflammatory connective tissue disorder that can cause major body organ and systems to fail. So there are many different ways that lupus manifests itself in different people. Some people will have characteristic symptoms. Like I said, it could affect one organ or it can affect multiple organs. The patient may have a rash that moves from place to place on the body, or something affecting the stomach one day, and then next week it will be, pain in the lungs or the heart. So there's spontaneous remissions and exacerbations. And it's when ANA affects the DNA, which develops these large immune complexes. Anti-nuclear antibody is what this acronym is. So the patient who has lupus develops anti-nuclear antibodies that affect the DNA, which develop these large complexes. So this is, by and large, a disorder that affects women more than men. Women typically 20 to 40. Usually it is diagnosed around about a woman's childbearing years. Black women in particular are at 8 times the risk. There is a genetic component to it. They haven't completely figured out the different issues. It's underway. It's something that is being studied, and it could be there may be an environmental link to it too. Could be something that the patient was exposed to in the environment. Personally, my mom She didn't have a family history of someone with autoimmune disease, but you have to understand, I mean, this is a fairly new diagnosis. Like, just on a personal level, I'll mention that, she was, for a while here in Southern Illinois, they didn't know what was wrong with her. They thought she had some kind of blood disorder, but they couldn't narrow down exactly what it was. And this was in the mid-70s, until she saw a specialist, and they said, I believe you have lupus. And ever since the 1970s, they've learned more and more about autoimmune disease and lupus, to where now, I mean, there are rheumatologists that treat patients with lupus. Okay. So the way it manifests, it's a type 2 and a type 3 hypersensitivity reaction. So we'll draw labs. We'll draw an anti-nuclear antibody lab, and the symptoms that you might see with lupus is flares of joint pain, skin involvement. The patient may have inflammation of the vessels or a rash. And like I said, these large immune complexes get lodged in the kidneys, so it causes the patient to have renal disease 40 to 50% of the time. My mom eventually went into chronic renal failure with as a consequence of lupus. They will develop some anemias. I know she did have some anemia issue. She definitely had skin involvement. She had the rash. She had flares of joint pain. Cardiovascular disease. She eventually developed heart failure. And then common symptoms: rash, photosensitivity. These folks, they have to wear glasses outside. They have arthritic issues. They have inflammation of the vessels, renal dysfunction. They can develop neurological disorders and blood. You will see when you draw up labs, you'll see some different labs for them as well. Changes in their white blood cell counts, that kind of thing. So anyway, here is the characteristic SLE butterfly rash. Now, my mom never had this rash, but so it's not a predictor of, oh yeah, this patient doesn't have lupus because they don't have a butterfly rash. It, like I said, lupus will manifest itself in different ways. So that's one hypersensitivity reaction disorder. Another one is transfusion reactions. So if you are type A, and that means that you will not react to type A antigens. If you're type B, that means that you will not react to B antigens if you're given blood. Now, if you're type AB, then you will have no problem with type A or type B blood because you're the universal recipient. You have antigens, you have antigen antibody. You will not produce a reaction because your body recognizes the A, the B antigen as self. So you are the universal recipient. Now, O has neither of the antigens. So a type O person doesn't have A or B antigens at all, and they are the universal donor. They can donate blood to any of the other people. Okay? So one thing that some of you might realize, folks who have had children, is they will, when you become pregnant, they used to do this when you got married. I don't know if they do this as much anymore, but after you become pregnant, they will get a blood sample, and they will check your Rh factor, and they will test to see if you're at risk for any hemolytic disease. They will test to see if you're Rh positive or Rh negative, and if you, and I can't say for sure, if you do have RH, well, actually they'll check your husband too, or the person that is the father of the baby. And if you don't match up your RH factor, then you may need RhoGAM to decrease the incidence of a reaction of when you deliver. Okay, so alloimmunity, transplant rejection. So there's different types of transplant rejections that they're part of this immune system response. So we can have a hyperacute rejection. Well, think about this. Transplant, when you are transplanting an organ into another person, they can try to match up that's transplanted organ the best they can, but to a certain extent your body will still recognize that organ as non-self. So you can have a hyperacute reaction that's very immediate. Your body will trigger blood clotting in that new organ. It will trigger, and when it triggers the blood clotting, it causes necrosis, and it causes the white blood cells to start attacking it and killing that organ. So people who are at risk for hyperacute reactions are people who have donated organs people who previously used donated organs that are different from their own, if they've received multiple blood transfusions, if someone has had multiple pregnancies, and if they've had a previous transplant, they're at risk for a hyperacute reaction or rejection. So acute rejection happens 1 week to 3 months after transplant, and that's when there's a longer, little bit of a delayed reaction, where you start getting some inflammation within that organ itself, and the inflammation actually causes the tissue to become necrotic, and the cytotoxic T cells and the natural killer cells penetrate and start the inflammatory response. Something I didn't mention with the inflammatory response is that it's a great thing to a certain extent, but actually inflammation can cause a decrease in blood flow to areas. So that's why I'm putting inflammation in the immune system up front in this course, because anytime I want you to understand inflammation, because when you have inflammation in an organ, then that inflammation is going to cause decrease in blood flow to that area. So this is an example of that, where you have the inflammatory response that actually cuts off blood flow and causes the area to die off or become necrotic. So, and then we also have chronic rejection, and this is when people have chronic inflammation and scarring post-transplant, and this chronic inflammation that in time produces scarring. It causes more occlusion of that area, and then eventually decreased function of that organ. Okay, so what has to happen before I get into AIDS? Go back here. What has to happen with patients who have what we do is we go ahead and they take immunosuppressant medications probably the rest of their lives to decrease the likelihood that they'll go into rejection of that organ. So when you get a transplant, then you typically are put on some kind of immunosuppressant therapy to decrease the likelihood of these different types of rejections happening. Okay, so now let's talk about HIV and AIDS. It's an immune system disorder too, acquired immune deficiency syndrome. Identified in 1981, 2017, we have a larger number of the population who are living with HIV and AIDS because treatment we've developed new medications that we've developed medications that help with prophylactically help the patient who's positive for HIV, and then also treatment of the patient with AIDS. So 75% of the population know their HIV status. And like I just mentioned, access to antiretroviral therapy has made HIV and AIDS more of a chronic disease than a disease where death is the common end result. Here I have a map from 2017 that shows you the prevalence globally of HIV. So, it's not as prevalent in Europe, the Western Pacific, Southeast Asia. It is most prominent in areas in Africa and areas in the Americas. And this is a map from 2017 of what the United States looks like. So the more urban areas, I don't know if I could say that's true though. I guess we could say that. The darker the color of blue, the more rates of HIV per 100,000 people. So you see Florida, Louisiana, Georgia, New York, New Jersey, a lot of the New England states, some of the southern states, and Texas and California, Nevada, Arizona. I guess the more densely populated areas in the country, although, we've got Chicago, Illinois is still, overall, Illinois has a lower rate than these other areas. But just to give you an idea of how HIV is affecting our country, I thought I would share that. Okay, so this is what happens with HIV. Okay, so HIV, what we have is we have CD4 T lymphocytes, and we have these receptors. So what happens with the HIV virus is it docks onto this receptor that is, this is our normal CD4 T lymphocyte. And HIV can readily dock onto this receptor, and what it does is it changes the DNA makeup of our CD4 T lymphocytes. So it basically hijacks our immune system and changes the DNA of these T lymphocytes. So just know HIV infection does not equal AIDS. An AIDS diagnosis is determined by the CD4 T cell counts. So when someone's HIV positive, we start checking the patient's blood periodically and looking at the CD4 T cell counts or the presence of an opportunistic infection. Usually, a patient who develops AIDS, an example of an opportunistic infection might be thrush in the mouth, or some infection where the bacteria is just looking for a host to infect. So beginning HIV symptoms, the patient will have fever, night sweats, chills, headache, muscle aches, rash, sore throat. The person might think they have mono or viral meningitis, but then they get better. But what happens is that war starts going on where the HIV virus starts infecting the CD4 T cells, and it starts dropping them in normal. So this is when this drops, when our immune system has been compromised and we have a decrease in these, we start developing a higher risk for opportunistic infections. So like I said, the AIDS diagnosis is made if the CD4 T cell count drops below 200 or less than 14%, or the patient has an opportunistic infection. So there are different classifications for HIV, 4 stages. So stage 0 is when the patient has a positive HIV test within 6 months of a negative. So then stage 1 is when they have a confirmed infection. We start seeing the CD4 T cell count. It's still greater than 500 or greater than 29%, and they don't really have an AIDS defining illness. We just see they have HIV and a decreased CD4 T cell count. So then the person moves into stage 2, where they have the HIV, they're positive, but the CD4 T cell count starts dropping. So stage 2 is when they're at 200 to 499, or they're between 14% and 28%. And there again, at stage 2, they still don't have the defining illness. But then by stage 3, we see the HIV infection, the CD4 T cell count drops even more to less than 200 or less than 14%. And then the patient actually does have the defining illness. And the stage unknown is when someone has a confirmed HIV infection and we don't have any info on their CD4 T cell count or percentage or an illness. So if we're unable to stage, then we say stage unknown until we can. So our assessment for a patient who has HIV, we go off their history. On the physical assessment, we're looking for those clinical manifestations of HIV I just talked about. But then we start looking at infections that are opportunistic. So fungal infections like a thrush in the mouth, or Candida albicans, viral infection, fungal infection, bacterial infection, protozoas infection. Some examples: TB is a bacterial infection that some patients who have AIDS develop tuberculosis. Cryptococcosis is a lung infection, and pneumocystis jirovecii is also a respiratory infection. So actually HIV and AIDS can cause malignancies. It can cause types of cancers called Kaposi sarcoma and malignant lymphomas. And it actually can cause some endocrine complications as well. And, as AIDS progresses, unfortunately, if we don't have adequate control, the patient will develop a type of dementia and wasting and skin changes as a result of the infection. And that's the end of my PowerPoint. So I'll go ahead and get this one processed, and I will be putting both of them up on in Evolve. Thank you.